Okay, good afternoon, everybody. I'm Anna Plotkin. I'm Director of the Continuous Professional Development for the Department of Laboratory Medicine and Pathobiology at the University of Toronto. I'm really happy to introduce our new community of interest in hematopathology. The organizing committee worked really hard preparing for this first session, and I would like to thank you all for joining us, and hopefully you will be an active participants of this session. I would like to introduce Rosemarie Tremblay, who is a moderator for this session. She works at the University Health Network, and she will also introduce the organizing committee, and she will take over for the rest of the session. Rosemarie.
Thank you, Anna. So welcome, everybody. Thank you for joining us for our first Hematopathology Community of Interest meeting. Just a few housekeeping details. We ask you to please mute yourself when you're not presenting or asking a question, just to makes it easier for everybody to hear what's happening. And we encourage you to have your videos on if you can, or if you feel like it, because it makes it a little bit more lively for the presenters, I think. And this meeting will be recorded, so the recordings would be made available to either to people who couldn't attend. And we will have various case presentations today, and we will. I encourage you to post questions in the chat, or after each case, we'll have a few minutes for questions, and then we'll also have sometimes probably at the end of the meeting to go over anything that wasn't covered earlier. And since it's our first meeting, I just wanted to take a few minutes of your time just to introduce our organizing committee and the committee of interest itself. So we have Rashmi Goswami from Sunnybrook Health Sciences Center. We have Sadaf Naman from Mackenzie Health, Sarah Morgan from Markham Stouffville Hospital. We have Adam Smith from UHN, and myself, also from UHN. And why are we having this hematopathology community of interest? Well, as we all know, hematopathology is complex, it's rapidly evolving. It often requires integration of ancillary testing for final diagnosis. And there's also a lot of gray areas where there can be some variability in practices between laboratories. And so we felt that there was a need for a forum where both academic and community pathologists, and also all the clinical scientists that have an interest in hematopathology, can meet to share interesting cases, discuss ongoing challenges, and also exchange knowledge in a friendly, informal, and collegial manner. So our goal is to focus more on practical knowledge and discussions rather than high-level updates on scientific knowledge, because there's other platforms and conferences and forums for that type of thing. So really what we want to focus on is reviewing common entities, but perhaps with unusual presentations, potential pitfalls, discuss new or reclassified entities, review interesting cases, and also discuss like the ancillary testing that can aid in diagnosis or prognosis of cases, discuss best approach to rare entities or best approach to workup of hematopathology cases, and also at times receive expert presentations from involved clinical specialties or other specialists and experts. And there's a number of activities that we can use. We really want this to serve the needs of our community. So today we'll have case presentations and discussions. We thought at times we could also have some formal presentations if, for example, there's updates in classification or there's significant publications that can impact our current practices, have roundtables on challenging topics. Sometimes also maybe presentation from clinicians to highlight the impact of our diagnoses on patient management, and review, what are the distinctions that matter, because they really lead to different treatment for our patients, and also have presentation by clinicians, clinical scientists, to present the limitations of ancillary tests and discuss how to integrate finding. And really let us know if you have any suggestions of topic, of presenters, of activities. As I said, we really want this to serve the needs of our community and to be interesting and engaging. And so without further ado, we will move on to our presentations. So I think, Sarah, you can do the screen sharing, and I will just introduce our speakers at the same time. So we have Dr. Bo Ngan. Just a second. I cannot see my notes. So we have Dr. Ngan, who is an associate professor at LMP University of Toronto, who's part of the division of pathology in the Department of Laboratory Medicine at Sick Kids. He has a special interest in lymphoma and lymphoproliferative diseases, has a previous fellowship with Drs. Ronald Dorfman, lymphoma immunohistochemistry with Dr. Roger Warnke, lymphoma molecular pathology with Michael Cleary at the Stanford University Medical Center. He's been a lymphoma pathology consultant at Sunnybrook Health Sciences Center and Bayview Cancer Clinic, Singapore General Hospital. He's currently a pediatric pathologist at Hospital for Sick Children, and he's interested in rare diseases and pediatric surgical pathology, and he's the author or co-author of more than 130 papers and 5 book chapters, and also the co-editor of the pediatric head and neck textbook. We also have Dr. Sarah Morgan, who's part of the Department of Laboratory Medicine and Pathology at Markham Stouffville Hospital, Oak Valley Health. And she did her anatomic pathology residency and hematopathology fellowship at U of T from 2014 to 2021. And she's been a surgical pathologist and hematopathologist at Markham Stouffville Hospital, Oak Valley Health from July 2021 to currently. She's authored several peer-reviewed articles, and she has a special interest in lymphoma. And finally, Dr. Katie Chun, who's part of the clinical laboratory, who's the clinical laboratory director in genome diagnostics at the Hospital for Sick Children, who's an associate professor at the Department of Laboratory Medicine and Pathobiology at U of T. And she has more than 20 years of experience in clinical genetic diagnostics. She's a member of several provincial and national committees, including CCO, Provincial Genetics Secretariat, IQMH, and CCMG. And she has leadership role in promoting and improving medical genetics education and training, also leadership in quality assurance and improvement of laboratory genetic methodologies. And she's interested in enabling transition of new genomic findings to clinical genetic testing with a particular interest in cancer. And I'll let you go ahead with your presentation.
So can you see my screen, Rosemary?
Yes.
Okay, I'm gonna get started. Thank you for the introduction. And as Rosemary mentioned, this first case presentation is shared between Dr. Bona and Dr. Kathy Chun from the Hospital of Sick Kids and myself, Sarah Morgan from Markham Stouffville Hospital. So our patient is an 8-year-old boy who presented with nasal obstruction. He went ahead and had some imaging. A CT scan of the head and sinuses showed complete opacification of the posterior nasal cavities with near complete obliteration of the nasopharynx, and the findings were concerning for a neoplastic process. The MRI confirmed the findings as shown in the images and showed a large nasopharyngeal mass, about 5.4 centimeters, with no definitive invasion of surrounding structures. The patient was seen by a head and neck surgeon, and a plan was to do adenoidectomy and resect the nasopharyngeal mass. And also because the lymphoma was in the differential diagnosis, a lymphoma protocol was also planned. Due to unusual findings during surgery, a part of the nasopharyngeal mass and adenoids was sent for intraoperative consultation. I was on call that day, and I looked at the tissue. It looked a bit unusual. It was sent as fragments of tank pink tissue, which looked rubbery, and we did the whole smear, touch preparation, frozen section, made sure to keep a fresh part for flow cytometry and fixed to rest in formalin for permanent section. So on the screen on the left side is a low power of the smear, and on the right side, we predominantly see small cells and a few intermediate cells, and we see also apoptotic bodies. On touch preparation, in the upper part of the screen, we see it's a cellular specimen with a lot of lymphoid tissue. And in the lower part, we do see mostly intermediate sized cells. They look monotonous, and they have this tingible body macrophage look or apoptotic look that's conspicuous. The frozen section part that I got was predominantly squamous epithelium of the adenoids, and in the subepithelial tissue, there was mostly a nodular lymphoid infiltrate. But when I looked at it as seen on the right side, it was mainly formed of small lymphoid cells, and still the apoptotic bodies were there. So at this point, I was thinking the overall findings are very unusual. And I was feeling that this is going to be a lymphoma. But what I have on frozen sections is not really very supportive. The cells are mostly small. And I was wondering, am I dealing with the florid hyperplasia? And these are tangible body macrophages of a germinal center, or am I dealing with a neoplastic process? So I signed out the frozen section as dense lymphoid tissue with atypical features. I gave my differential and deferred the final diagnosis to permanent. On H&E, so the specimen was submitted in 7 blocks. It was quite big. And the main findings were, as we see on the screen, a diffuse effacement of the architecture of lymphoid tissue. And this was mainly by a typical lymphoid infiltrate that was in 2 forms, either diffuse sheets of lymphoid cells or a vaguely nodular architecture as seen in the lower image on the screen. On higher power, the nodular areas mostly showed small cells, but the diffuse areas showed more of an intermediate sized cells, which look monotonous. And as we see, there are mitotic figures which were conspicuous. The chromatin looks open, and there are a few nucleoli as well. The most prominent feature throughout the tumor was the presence of these apoptotic bodies, which were very conspicuous, and on low power and high power, as shown on the screen, which imparted a starry sky appearance. I will have the first poll question. I know that at this stage, it's a bit unfair to ask for a diagnosis, but I want to know the impression of the audience from the given findings, the clinical and histological features. Do you think we're dealing with reactive hyperplasia, an indolent lymphoma, a high-grade lymphoma, a lymphoblastic lymphoma, or a myeloid sarcoma? If we can have the poll. Thank you. Okay, we can end the poll here. It seems that most of the audience are inclining towards more of a higher grade lymphoma. Some are thinking of lymphoblastic lymphoma, and a few are thinking of either indolent or a reactive hyperplasia. If you can allow me to just keep going, thank you for your input. And the actual diagnosis will be revealed later in the presentation. So I want to show you what we found on immunohistochemical stain. So this is a B-cell process that was diffusely positive for CD20 and PAX5. It was of a germinal center origin with diffuse positive CD10 and BCL6, but a negative BCL2. CMYC was negative and IBER-ish was negative with appropriate control. Impressively, the Ki67 was quite high with about 90% proliferative index. MUM1 came back negative, and CD23, and mirroring that was CD21 as well. It showed persistence of the follicular dendritic cell meshworks, and I was wondering, does this only apply to the nodular areas? So I repeated those 2 stains on 4 different blocks, and I got the same findings that the follicular dendritic cell meshworks were preserved throughout the tumor. The flow cytometry came back as kappa-restricted B-cell population, which was positive for CD10 and CD38 and negative for all other tested markers. So we're dealing with a B-cell lymphoma of germinal center origin that's negative for BCL2, MYC, MUM1, TDT, and CD34 with a high proliferative index and a negative IBER-ish. At this point, I came up with a differential diagnosis based on pediatric lymphomas. I'm not an expert in pediatric lymphomas, but you never know what will come across your desk. So I was thinking what pediatric lymphomas could involve the Waldeyer ring, which includes the tonsils and the adenoids. So I came up with pediatric type follicular lymphoma, the large B-cell lymphoma with IRF4 rearrangement, Burkitt, and DLBCL. I started excluding certain entities based on whatever was making the case included or excluded. So for example, I excluded the IRF4 because I had a dead negative MUM1, And I also had a lot of mitosis and apoptosis, which will not go well with this entity. Although it's known to affect kids and adolescents in the head and neck area, but still there were confounding features. I felt that there were some features that would support Burkitt lymphoma, but because of the hallmark MYC, which was negative, and EBER, I was not supportive of this diagnosis. I excluded the LBCL based on the persistence of follicular dendritic cell meshworks all over the tumor. And I was left with pediatric type follicular lymphoma, which I thought was reasonable. This type of lymphoma is known to occur mainly in the lymph nodes of the head and neck, but few cases have been reported in the Waldeyer ring. They could have high-grade features deceptively despite excellent prognosis, and they could have this look with serpiginous follicles that are expanded, and they could have cells as well that have a high-grade feature reminiscent of the follicular lymphoma grade 3B, and they can have Ki-67 from 30% and above. So I felt comfortable diagnosis in this case as CD10 positive B-cell lymphoma fever, pediatric type follicular lymphoma. But this is not the end of the story. The patient was referred to the Hospital of Sick Kids because our oncologists do not really treat pediatric lymphomas, and a pathology review was requested. And I will pass on the talk to Dr. Bonan to explain. He was the pathologist who got the case, and he is the expert in when it comes to pediatric lymphoma. So I will leave it for him. The podium is yours, Dr. Ngan.
Thank you, Sarah. I treasure the experience of doing consults. And as usual, unusual cases do come by, and in particular in the setting of pediatric patients. This is extremely rare types of lymphoma, and I will go through the rationale and the evidence to support that. All right, so to start with, I examine the tissue. And as Sarah has addressed, that there's a very close trophic relationship with disbanded follicular dendritic networks. And that's evidenced by the immunostain. But if one focuses in some areas, it has some deceptive features seen. This is extremely challenging. On the left, you would see a typical high magnification of the lymphoma, and it has only one of the three features of Burkitt's. In my days with Dr. Ron Dorfman is that he told me there's a triad to diagnose Burkitt's. One of them is shown here, dead center. Lymphoma cells seldomly have 90-degree cell borders. You can see these are perfect square cells. So it resembles those Roman Greco tile displays of images. They use, this is like mosaics. So if you see a mosaic pattern, you get one of the 3 points for Burkitt's. Now this only occurs if you have a very well preserved and very well fixed thin sections. The second thing we get side railed in this lymphoma is what appears to be like starry sky is actually apoptosis. These lymphoma cells undergo tremendous apoptosis. And the third thing in Burkitt's and the triad is you like to see a lot of mitotic figures. So, to prove the point, it's not starry skies. I did a 163, which is a activated macrophage marker. There are not too many areas with that. So we know that we are tricked by this lymphoma. So the next slide. And Sarah's observed that there are residual follicular organization. So I choose examples of where I find it. I recall way back when Dorfman told me he had seen follicular Burkitt's, but he had never shown me one. I was with him for 2.5 years. And you know, those days we're early with a lot less technology than today, but nevertheless, it's imprinted in my brain. For all these years, I'm witch hunting for follicular Burkitt's. Next slides. And as we talked before, there's a dendritic network that is still associated within the areas with expanded or primitive, smaller follicular organization. Next, please. And they come up with a differential. First is that it's extremely rare for what I've seen. So it needs a lot more workup. This is not ordinarily that I would go through diagnosing lymphoma. The second follicular type is the pediatric type follicular lymphoma, which does occur in the pediatric tonsils. And Sarah already addressed this entity. I'll show examples of that. And in pediatrics, which is abundant in, okay, so there's an example of pediatric type follicular lymphoma. Here, ideally, once you see lymphoid follicles that are vastly expanded, no different than the adult one, thin mantle, and then some focal areas are sharing and spilling over of these lymphoma cells into each other. They do have grade 2 to grade 3 types of cytology. And they don't have any polarization. There are no pale and dark zones. And we have very little tools to diagnose this because in the pediatric type, the immunostain and will not reveal that there is any BCL2 staining. So we lack that nice marker, which I worked up at Stanford when I was there for adult type follicular lymphoma. Next thing. And as said before, I've seen a case of IRF4 rearranged diffuse large B-cell lymphoma that colonizes a tonsillar lymphoid follicle. This is the diffuse area on the right and the residual lymphoid follicle in the middle. So always beware of that. And again, on the right-hand side, you can see a pseudo starry sky. And so the workup next one, which is appropriate, next slide, with the use, they will co-express MUM1 as well as BCL6, and they're fairly high in MIP1. Next slides, and not forgetting pediatric setting, there is leukemias. And I recently got a case that I thought, with a starry sky pattern, I got a follicular Burkitt. Next slide. As it turned out, next slide, please, it fools me because this one was CD20 negative. When I do CD20 in deep, it will highlight all the follicles that these leukemic cells invade, but look and behold, the TDT is positive. So this is a case that mimics follicular Burkitt's, but it colonizes lymphoid follicles. Next, please. So obviously the next step in the diagnostic regimen, if one think about Burkitt's, is look for whether it has a c-MYC translocation. So I sent the tissue slides for a FISH analysis, and following that up, when I get back the results that MYC is not translocated, BCL2 as expected not translocated, because the co-translocation lymphoma, so-called double hit lymphoma of diffuse large B-cell lymphoma that acquires c-MYC translocation is extraordinarily rare to non-existent in the pediatric age group. But it's not uncommon, you'll see it in the adult practice. So then I decided the chromosomal structure should be analyzed. And I don't know, no, next then, let's go on, Sarah, you decide. Yeah. Okay, so I'll let Dr. Kathy Chung take over.
Okay, so as Bo just mentioned, we did FISH on the paraffin-embedded tissue sections. We used the IGH BCL2 probe set to look for the specific translocation. And the probe strategy for this probe set is a dual color, dual fusion probe set strategy, so that if there is a rearrangement between IGH and BCL2, half of the probes of each probe set will go to the other half. So when there is a rearrangement, you will expect to see 2 fusion signals on each derivative chromosome. And then you'll also expect to see green for the normal immunoglobulin gene and an orange signal for the BCL2 that isn't rearranged. However, if there is no rearrangement, you're just going to see two oranges and 2 greens, which is essentially what we're seeing in the FISH image to the left. Next slide, please. So the MYC probe is a different strategy, actually, because we don't really care who the partner for MYC is. We just want to know that MYC is rearranged. So in this case, in a normal cell, you actually expect to see 2 fusion signals because the orange and the green are so close together that in interphase nuclei, it's going to look like a fusion. if you had a rearrangement of c-Myc, you actually expect to see the orange separated from the green signal. So you would have an orange, a green, and then a fusion signal on the normal unrearranged locus. But here we're seeing two fusion signals in all the cells, so we know that MYC is not rearranged. So the patient is IgH BCL2 negative, as well as c-Myc negative. And then so we went on to do microarray analysis on the paraffin section. And this is, we saw that the genome was relatively quiet except for chromosome 11. And the blue color indicates gains and the red color indicates loss. So we see that the abnormalities are basically localized to chromosome 11, more specifically on the long arm, which we call 11q. We see that there are gains in the proximal 11q region, all the way down closer to the telomere. And then we see a huge loss on 11q, which includes the terminal region. Next slide. This is a whole genome view showing essentially the same thing. The top is showing copy number. So we see again on chromosome 11, there is gain on 11q and loss at 11q ter. And the second and third panels show SNP information. So it gives us different information that's not copy number. So when I saw this, I went and did a bit of literature search to see what we're looking at. And I found some publications pertaining to this specific abnormality. Here again, in this publication, we see below copy number information that looks really, really similar to what we found. So the line there in the middle indicates the centromere. And so we see that the gains are again on 11q and loss at 11q ter. Next slide, please. And this again is another publication showing a bunch of cases similar to ours. The green indicates a single gain and the dark green indicates more gains than just the single copy. The red indicates losses. Again, this is our patient result to the far right, shows extremely, extremely similar results to the group of patients shown in that publication. And just to point the genes out, that they do correlate with what was found in the publications. And this was actually pivotal in coming up with the final diagnosis, and I'll let Bo continue from here.
So this is very, very interesting finding. So I told myself it's time to hit the literature for some more. As you know, the 2016 WHO book on lymphoma has a tentative category of Burkitt-like lymphoma with 11q aberrations. So what does that mean? So the original case was first discovered in or described in 2014. And as I say, the WHO fascicle is in 2016. And as the last paper that Dr. Chun showed is in 2018. That is a paper that follow up with just focusing on 11q aberrations. And they this is a group from Poland published in the AJCP of January 2018, volume 149, page 17 to 28. So very interesting when they group together three types of lymphoma: c-Myc positive Burkitt, c-Myc negative Burkitt, as well as diffuse large B-cell high-grade lymphoma with c-Myc translocation. They find 11q anomaly. So now, as our knowledge and our technology are more applicable and we're analyzing more cases, we find that 11q associated with Burkitt is quite peculiar, that it will bridge over different type of morphology. So, okay, next. So in this earlier paper from a large group from the Spanish group. They have used the so-called the target next generation sequencing approach to analyze. Next slide, those are the platform they use. And I dig into the literature and notice in case 7 here, they have one case of Burkitt lymphoma in the cervical lymph node. And the immunocharacteristic is listed here. The only thing they see in case 7 is that it's a CD10 and BCL6, similar to ours. So next. And this is the case that Dr. Elaine Jaffe's group tabled and put into the fascicle of 2016 WHO. And you notice in the panel C2, this is from this paper, they observe one example of a cervical lymph node of Burkitt lymphoma that has these trophic relationship with a lot of residual dendritic cell network. So that is very much similar to our case. So I decided to go further to analyze this one. So in their publication, they also use targeted next-gen sequencing and focusing in lanes number 7. They detected a variety of gene mutations. They see there is VUS of variant of unknown significance or variants in c-MYC gene, and GNA13 and ETC1. Now remember, ETC1 was the gene locus 11q. So next. So this is what I'm using now. I don't want to tell you that this is mandatory for any diagnosis. This is more in terms I use it to generate new knowledge. The important thing that I find this as adjunct additional analysis with targeted next-gen sequencing is give me a glimpse and a handle to flag out the pediatric type follicular lymphoma. Unfortunately, this long laundry list I asked our scientists to do is not really foolproof. The highest number of genes in pediatric type follicular lymphoma is a TNF SF14 and the MAPK gene, but the score rate is less than 40%. And a small number of analysis, we confirm that. KMT2 occasionally is involved. But in contrast, in this particular patient, I was eyeing for GNA13, like the other paper, we didn't find it, but we picked up another gene mutation, which is P53. It is useful in that setting is because low-grade lymphoma never have P53 mutation. So that's very unique. Second, next slide then. We also picked up by this analysis another gene that is known, that is flagged out as PIK3CD gene. This has never been reported in Burkitt's lymphoma, except in one case, which I'll cite later on, but it has a germline mutation association. These kids with immunodeficiency, they have lymphoma, but in this setting, this child is so old, there's no immunodeficiency. So this is not a germline mutation, it's an acquired mutation during the development. So one publication appeared in Genes Chromosome Cancer describing a progression form of Burkitt, and they found PIK3CD gene. So this is the citation I use next to it. So, all right, so the case wrap up is that morphologically, it fits in the Burkitt lymphoma. The morphology is quite diverse. As I pointed out in the Polish study group, that they see that the 11q aberrations can occur in Burkitt's with a variety of histologic features. The unique finding in our case is additionally, we found there is a driver gene involved. One is P53 and there's PI3CK gene involved. And it does not have that spectrum of low-grade pediatric type follicular lymphoma. So this is a very comprehensive in the quest of generating new knowledge to help us to understand both the biology as well as the diagnostic notation that Burkitt's lymphoma can have various subtype of anomalies that are most of them are MYC translocated, as a subset of them are not, and then the one without c-MYC translocation can often have another aberration in chromosome 11q, and it is not strictly defined by morphology as well. And this brings awareness to all of our working group for today. Any questions?
Thank you so much for a very interesting case. If anybody has questions, please just raise your hands so I can see and call out on you. Just in the meantime, I had a quick question. I found, this is not an entity that I have a lot of experience with, but I found a paper in American Journal of Surgical Pathology where they kind of mentioned that the cases that they had with the 11q aberration pattern often had what they called strikingly coarse apoptotic debris that they thought facilitated the recognition. I'm just curious, is this something you've kind of had in your morphology, or was it striking?
It's a very fair comment from HA Search Path. That certainly fits into this one. That really fooled us. And it actually have very, very prominent clusters of confluent apoptotic lymphoma cells. There's streaks and pools of them, actually. It could be an interesting feature, but in the Polish study with 11q, they did not show any of that in their panel. I have them on my screen, but I can show you briefly. If you allow me to share screen, I would flag it up, if I may. Okay, so let me see here. I don't use that. No.
We'll go to Ali after.
Yeah, okay. So, but anyway, maybe I can't do it now, but I could have incorporated that earlier in the presentation. So yes, I think it's good that we, in fact, if I intend to show, if you look up the paper in HACP, the image that is shown in the figures C, I forgot what figure number it is. It's only the part that has histopath in it, does have that. Yeah.
Mm-hmm. Interesting. Ali, I think you have a question.
Go ahead,
yes,
please.
Yeah, do you hear me okay?
Yes, I do hear you.
Okay. Thank you very much, Sarah and Bo, for very excellent presentation. That's really rare entity that we have. Two things. First, I guess that CD23 stain that you showed us, Sarah, that's not compatible with pediatric type follicular lymphoma. That's kind of disrupted, and follicular lymphoma, it shouldn't be disrupted like that. Second thing, that you also both showed us a recent publication. I think that hematological paper kind of made the deal that this so-called Burkitt-like lymphoma with 11q aberrancy is not related to Burkitt. So that's the reason in the upcoming WHO, they will separate these two. So we're gonna call them large B-cell lymphoma with 11q aberrancy because they are not MYC kind of driven lymphoma. So Burkitt is a MYC-driven lymphoma, but these are not apparently.
That explains why they have a hyphen as a Burkitt-like. I mean, that's because most of us practice histomorphology. WHO, the new edition is controversial. 3 weeks ago, heard a presentation from Dr. Elaine Jaffe, is that the IRAC group decided they don't invite any of the previous chapter contribution from the previous edition. They go on their own, and Dr. Jaffe started her own manuscript or fascicle from the Chicago meeting last year. So the world is now split again, just to add on more complexity for us who wants to seek consensus on how to name lymphomas. Let me quickly say, for the pediatric setting, we make a lot of diagnosis. We have always been mindful, what will our clinical clinicians do with our diagnosis? As you know, that in pediatric Burkitt treatment, there is no difference than that of adult. In adult, our oncologists always pressure us to classify it accurately because they have to do CNS prophylaxis for Burkitt's. But that is not the case in pediatrics. In pediatrics, for this kid, it has now received a combination chemotherapy with rituximab added onto so-called colpadum. It's a shortened form of cyclophosphamide, oncovin, prednisone, adriamycin, doxorubicin, and the methotrexate. So it has been well oiled and tested in the pediatric oncology group, and that's the preferred regimen for treatment of Burkitt's. It has also been applied in modified form in anaplastic large cell lymphoma treatment as well. So the treatment aspect is quite different in terms of our reflected on the demand on our subclassification in pediatrics.
Thank you so much for this very interesting case. So I think in the interest of time, we will move on to Dr. Tierens' presentation. But if there are any additional questions, we should have probably a little bit of time at the very end of the meeting, or just put them in the chat. So Anne, are you able to share your presentation? And I'll just introduce, so Dr. Anne Tierens, who has joined the University Health Network in 2013, and also is the director of the flow cytometry lab, and previously was a senior consultant hematopathologist at Oslo University Hospital and director of the flow cytometry laboratory there, and also director of molecular pathology laboratory. Anne, are you able to share? Or would you want me to share the presentation?
I was trying to find it. I hope I can do it. Can you see something?
Yes, yes.
Is it in presentation mode or just?
Not yet. It's just as a.
I will try it now. Do you see it as presentation mode?
Not yet.
No?
Now, yes. Yeah,
okay.
Now it's good. Yeah.
So this presentation is put together based on the diagnostic process, which is not really was the right thing, but it was based on the clinical information we got. So it's like gradual building up how we came to the diagnosis. It's a rare case, rare presentation, but I think it was of interest for all of us. So this was a woman, 36 years old, presenting with a 1 month of worsening abdominal pain, malaise, drowsiness, and lethargy. Her previous medical history, she had asthma, sleep apnea, and she recently underwent bariatric surgery in December 2021. So when she presented, they found out at the emergency department that she had hypercalcemia, and they did some imaging because of the abdominal pain, and this showed diffuse osteolytic lesions. So the first clinical question that we got was, is this a plasma cell myeloma? So what they did is taking a bone marrow aspirate and send it for flow cytometry and morphology. Now the flow cytometry sample came first, and the laboratory, they saw the question plasma cell myeloma. So what they did is the plasma cell myeloma panel. The bone marrow aspirate, in the meantime, I looked at it a little later. It was hemodilute and didn't show any spicules, so it was more blood than bone marrow. But there was a CBC, and the CBC was as follows. There was a mild anemia, the anemia was normocytic, the platelet count was normal, but there was a lymphocytosis. So just going ahead, the myeloma panel was put up, and as you can see, the plasma cells here are the blue dots, and there is certainly, it's very obvious that there is a polytypic expression of the Ig kappa and Ig lambda, and the B cells can be checked as well. So there was no B cell lymphoproliferative disorder. So the lab called me and they said, what we have to do now, because I said the patient has lymphocytosis and B cells were normal. And I said, maybe put up the T cell panel. And this was done because of some strange lymphocytes in the peripheral blood film, which I will show later. So here are the results of this T cell panel. We didn't do a lymphocyte screening tube because we knew that the B cells were polytypic, so we went straight ahead and did all the T cell markers available here. On top, you see the pan T cell markers on the x-axis versus the site scatter. And when you look at the relative percentages, there is certainly a discordance between the percentage of CD3 positive T cells, which was about 9%, but the CD5 positive cells were 22%. So, and indeed, there was a discordant expression between CD3 and CD5. So there was a clear population of CD5 positive T cells, which did not express surface CD3, but there was a normal CD3 positive population as well, showing a normal CD4, CD8 ratio. In addition, the CD2 was similar to CD5, but there was also a loss of CD7. Again, these abnormal light blue cells here, these are CD4 positive and show the partial expression of CD8. Looking into a little further, we have a number of markers that can be used for different kinds of T cell entities, and these are shown here. It is very obvious that these abnormal CD5 positive, CD3 negative T cells, they were negative for CD26, which is quite unusual, and they showed a good expression of CD28. In addition, there was a weak expression of CD25, but no expression of HLA-DR. And then in our third combination for the T cells, we have CD10 and PD-1 or CD279A, and it also confirmed that the cells were weakly positive for 279. This was not necessary. There were the cytotoxic T cell markers done, but as we did not know originally what it was all about, so cytotoxic T markers were all negative as shown here. There was no expression of CD16. There is no expression of CD57, and there is no expression of 94. What was interesting is the lymphocytes. They were abnormal, and I'm going to show you a gallery of all these lymphocytes that were seen. It was mostly a blood sample. There is no doubt that you can appreciate that there were a kind of high number of lymphocytes that had abnormal morphology. The CD5 positive T cells, CD3 negative T cells, they represented about 50% of total lymphocytes, so they were could easily be appreciated on the blood film. There were small cells, there were medium-sized cells, and some were very, very large, so it was kind of a pleomorphic morphology. Interestingly, many of these lymphocytes showed kind of clefts or irregular nuclear contours. Some had flower-like lymphocytes. So far, we made then a diagnosis of a T cell lymphoproliferative disorder of CD4. It was about 50% of total lymphocytes and 13% of total leukocytes. So a bone marrow biopsy was, they could not take it at the first attempt. So what I asked for a bone marrow biopsy, I initiated T cell receptor clonality analysis, and as expected, it showed clonal T cell rearrangement. I asked for something else, but I think you will know what the differential diagnosis was. So this is a CD4 positive T lymphoproliferative disorder. I didn't make a poll. I apologize because it was a last minute preparation for this community meeting. So, but the CD4 positive T lymphoproliferative disorder, the phenotype could have been consistent with Sézary syndrome, a peripheral T cell lymphoma, not further specified, and another diagnosis, which it finally also was. So here, so they did a second attempt and took a bone marrow biopsy, and this is a general overview of the bone marrow. It was slightly hypercellular for the patient's age, but it showed a very nice trilineage hematopoiesis. Is a little more stimulated, but there were lots of plasma cells, but otherwise hematopoiesis seemed quite normal. Some details of this biopsy showed some changes along the trabecula, as you can see here. There is some streaming. There seems some kind of abnormal cells present. On the right, I think most of these cells are normal hematopoietic cells here, erythroid cells and maturing granulocytes, but scattered in between were some plasma cells and some very a little strange lymphocytes. Now, the patient has hypercalcemia, so this could explain it. Other areas showed this, many giant cells, and these adjacent to the trabecula, so these were kind of osteoclasts, so explaining the patient's symptoms, but it was really a remarkable picture. This is one area, but there were many trabeculae showing not that many osteoclasts near to the trabecula, but so that was very, very bizarre to find in the patient here. Now, this is, the patient showed, in addition to a diffuse infiltration of the lymphocytes, quite many lymphoid aggregates, and I hope I try to make two representative pictures here, and I hope you can appreciate that we see actually the same kind of cells that we have seen in circulating in the blood and also in the aspirate, the bone marrow aspirate, and these cells were really very abnormal, ranging from small to medium size and very rare larger cells, but the nuclear contours were irregular, and many of these cells show prominent nucleoli. In between, there were scattered plasma cells as well. So this is really the picture of these lymphoid aggregates as they appeared in the bone marrow biopsy. Another example is shown here. Again, we see many of these irregular lymphoid cells, prominent nucleoli, some may be flower-like. It's not that visible in the biopsy, but as I showed in the blood film, there were a couple of them. And again, quite many plasma cells along this, in these lymphoid aggregates here. As we had the results of the flow cytometry, I only stained for CD3, and this is a CD3 stain. And we knew that there was hardly any surface expression of CD3, so this is probably mostly a cytoplasmic stain, as you can really appreciate from the cytoplasmic stain here. The size can also be appreciated, really ranging from small to medium sized and a few larger ones. A couple of extra stains which is of interest mostly for therapy was the CD30 stain was done, it was negative. We did also a FOXP3 stain, which was also negative. And I did not do any additional immunohistochemistry stains because we had sufficient flow cytometry results to come to a conclusion. So here is the diagnosis. You probably guessed it. So this is an adult T-cell leukemia, and I think the patient is quite young for presenting with an acute phase, because most of these patients, the median age is between 50 and 60, at least in Japan. It seems like the presentation, the median age of presentation is young in younger patients for North America, between 40 and 50, but so she's quite young. And the additional test I asked for was HDLV1 serology, and it came back as positive as you can imagine. Now, many of these patients present with an increased LDH, and this is shown here. And this is an acute phase because there are 4 different subtypes, which I will show a little later. This patient had no history of opportunistic infection, as you know. ATL, often these patients have opportunistic infections like strongyloides is one of these. The patient, it was tested for that. She was negative. She had also, many of these patients have inflammatory symptoms. She did not have that. And and what is important, because this is an acute phase that one needs to exclude CNS involvement. unfortunately, only brain imaging was done. So in principle, one should take a lumbar puncture because this ATL acute phase does not always present with a lesion. The patient had, and I don't know whether I showed it, but they did an extensive imaging of the thorax and the abdomen, and she had only rather sub-centimeter small lymph nodes in the abdomen, so she had not really a lymphadenopathy. So there are four like classified cases. So there are the carriers. So and principle, well, the main features are summarized here. So there is the smoldering one, the chronic one, and the acute one. So this patient certainly presented with an acute adult T-cell leukemia and not the lymphoma. These two are considered as quite aggressive and need to be treated with chemotherapy and preferably also followed by allogeneic stem cell transplantation. This patient got show up and is scheduled for transplantation if they can go ahead. So you should have, of course, positive serology. In some, at least in Japan, but it's not a custom here in Canada and in the United States, one look for the integration of the provirus. So the virus, the viral integration site, so there are CD4 positive T cells that are infected by this virus, and the infection, and very interestingly, takes place decades before the patients present with symptoms. So, and this is also for probably she might have got the infection during breastfeeding, so a long time ago. And it is said that about a carrier can have like 10 to the 4th to 10 to the 5th, 10,000 above 100,000 infected CD4 positive T cells circulating there. In a patient with an acute phase, the lymphocyte count is elevated, so that was confirmed here, and she has definitely more than 5% abnormal lymphocytes in her blood. Many of the patients present with calcemia, but it can still be normal. Many also have increased LDH. This patient, I could not find any information that she had skin involvement. It was not mentioned, but of course she had extensive bone marrow involvement, and I have no information of gastrointestinal or CNS involvement. The CNS, the imaging, the brain imaging was negative. So this ATL, just shortly, is a multi-step oncogenic process, and the patients, the carriers, they gain driver mutations, and these driver mutations are detected up to 10 years prior to the diagnosis of adult T-cell leukemia. There are two oncoproteins of interest. I'm just shortly going to mention this is AZB and TAX, and TAX is the transactivator protein, and it's primarily this protein that is responsible for the proliferation, resistance to apoptosis, and genetic instability. But also TAX-infected CD4 positive T cells, they are immunogenic, so they are cleared away. So that's why the process can take many years. So when a patient is infected, you have a polyclonal virally infected population of CD4 positive T cells, and the virus genome is integrated in the human genome, and then as such are these oncoproteins and all the viral proteins produced. Slowly there is an oligoclonal expansion because these cells are they proliferate and they are resistant to apoptosis, and then because of the higher proliferation rates, they get gain of function mutations mostly in the T cell receptor and the NF-kappa beta pathway. There is also loss of function in the tumor suppressors, and there is also mutations in the immune response genes, and one of these is CXCR4. So ATLL is one of the hallmarks is the expression of the chemokine receptor type 4. Unfortunately, I think many of the labs do not have the stain for this, so we could not confirm it, but apparently 90% and more should be positive. And there is also mutation in the TAX, all the proteins associated with the TAX oncoprotein. And then you get ATL. So in between, there's decades and decades in between. This patient was rather young. The mutation profiling, so this was a study looking into the mutation, the gain of mutations in patients before they had presented with ATL, either the lymphoma or the acute phase. And what is typical for ATL is that a very high number of mutations that are found in this patient, and this is really because the DNA, there is a defect in DNA repair. Important is here the CCR4 in these 6 patients, 3 of them had these mutations. Frequent mutations are also present in PLCG1 is a proliferation pathway. So I'm not going into detail because I'm not an expert in ATL, very far from that, but it's probably interesting to see that there are quite a number of driver mutations that can be affected, and then there are co-occurring mutations as well. So with this, I'm going to end. I thought especially the morphology was very nice, and it is one of the messages here is that we often don't get the appropriate clinical information, so we are a little misled there sometimes. If we would have known that there was a prominent lymphocytosis, probably the flow lab would have initiated both the LST lymphocyte screening too, but anyway, it's sometimes not really, for the clinician as well, confusing. What I didn't tell the patient is from Jamaica, was originally, and her father died 2 years ago of ATL, so it's a very sad clinical presentation, especially also family related. She has a brother and a sister who are young, but so they will screen both of them for carrier presentation. So in the literature, I found that sometimes these patients are transplanted with like donors from their own family that are carriers. So, but then they check for the profile a lot. So this is interesting. But the patient itself, based on what I read in EPR, is really devastated knowing that her father died 2 years ago. So with this, I'm going to end here.
Thank you so much. Yes,
an expert.
Thank you for this presentation. If anybody has questions, just raise your hands or put them in the chat. Yeah, thank you for this interesting case. I think, as you said, we don't always have the clinical information, or the presentation can be deceptive. I caught a case of ATLL a year ago, and it was just, I was doing peripheral blood smears and I thought the lymphocytes looked odd. And in EPR, all we had was that the patient was coming to be seen by an ophthalmologist for uveitis of unknown etiology. And then, doing flow cytometry, we saw the abnormal population, and it's later on in the workup that they found that the patient had the HTLV1 and that this was ATLL. So sometimes there can be deceptive presentations. So did anyone have any questions? I don't see any raised hands. If you have any further questions, just put them in the chat, or we can keep them for the end. And so we will now move on to Alexsandra Paliga, her presentation. Alexsandra, are you able to share your screen?
Yes, I'm working on it. So I guess I'll share this.
So in the meantime, I'll just introduce. So Alexsandra was originally from Ottawa, where she did a Bachelor of Science in Biochemistry. And then she went to McGill University for medical school. She graduated in 2010 and started a residency in Ottawa in anatomic pathology. She then did a hematopathology fellowship at Oregon Health and Science University in Portland. And she then returned to Ottawa in 2016 and currently signs out both lymph nodes and gynecologic pathology at the Ottawa Hospital. And she's also the coordinator for the undergraduate medical curriculum, and she's hoping to start a hematopathology fellowship in Ottawa. So,
thank you very much, Rosemarie. Thanks for the introduction. Can you guys see my screen okay?
yes.
Okay. So I'm presenting two cases that I thought were pretty interesting and that I learned something from. And since they're both a bit related, I thought I would show them together. So case one is a 56-year-old male who presented to the ICU. He had a pleural effusion and neck and mediastinal lymphadenopathy. And the pleural effusion, of course, went to cytology first. And eventually it was transferred to the lymphoma service when the cells came back CD45 positive. So this is what the cells looked like in the pleural effusion. There's a hint of plasmacytoid morphology in the cells. And then there seem to be apoptotic cells in the background, suggesting a high proliferation rate. Here's the formalin fixed block. And so again, up here we can see a mitotic figure. Again, there's cells that really do have plasmacytoid sort of appearance to them. And this was the immunohistochemistry that came to me with the case. And so we can see CD3 stained some background normal T cells, but was negative in most of the typical cells. CD20 was completely negative. And CD30, interestingly, was very strong. I was actually very surprised about how strong it was. And then CD45 was positive. And so then this brings us to, with this panel in mind, we could ask ourselves, well, what's the differential diagnosis for a CD30 positive hematolymphoid malignancy? And so running through the list, most people would think of anaplastic large cell lymphoma, either ALK positive or ALK negative, and then Hodgkin lymphoma comes to mind as well. There's also CD30 positive large B cell lymphomas and peripheral T cell lymphomas, though these usually aren't as intensely and diffusely positive. You can have CD30 positive expression in sinonasal NK T cell lymphoma, and it has also been reported in myeloid sarcomas. And then finally, plasmacytic neoplasms can be brightly, strongly CD30 positive, which I think is something that is less well known among most pathologists. So additional stains were performed. ALK was negative, CD15 was negative, EBV was negative, pan B cell markers were negative, and pan T cell markers were negative. So then if we adjust our differential diagnosis, we could still consider ALK negative anaplastic large cell lymphoma T cell null type, but we really need to rule out the plasmacytic entities. So this was the CD138 and the kappa and lambda, and it was really not that impressive, a little underwhelming. Initially, the cytopathologist actually did these stains and he interpreted them as negative, but the CD138, on closer inspection, I did feel that there was some partial positivity in some of the typical cells. And then looking closely at the kappa and lambda, the lambda also seemed to show, the kappa was totally negative, but the lambda did stain some of those cells. So at this point, what additional stains could you do to confirm plasmacytic differentiation? And so, yes, I would agree with those answers. You could do both MUM1 and EMA, though EMA is much less specific, though MUM1 is also pretty unspecific. But EMA and MUM1 were both performed, and the plasma cells stained for both, or the cells stained for both, implying that they are indeed plasma cells. And so what additional stain would you like now to help solve this case? I took out the EBV in the final quiz because I already said it was negative earlier, but I see it's still there. The EBV is negative. So yes, I see that a lot of people went for additional markers to help tie this up, help put this into the plasma cell neoplasm category, so more like a myeloma. But given the presentation of pleural fluid and lymphadenopathy, I went for the HHV8. And indeed, the HHV8 was crazy positive. The most positive HHV8 stain I've ever seen, which made me really excited. So this essentially narrows down our differential to primary fusion B-cell lymphoma, but we also have to remember the other HHV8 positive lymphomas, which is HHV8 positive diffuse large B-cell lymphoma arising in multicentric Castleman disease. And then you can also get germinotropic lymphoproliferative disease. And so in this patient, so usually primary fusion lymphoma presents with a pleural fusion, as the name implies, but it can also be present outside of the pleural fluid in a solid form. And then any lymphoma can essentially involve the pleural fluid. Primary fusion lymphoma is rare and it's very aggressive, and it often is in immunocompromised patients. So usually secondary to HIV, but there are HIV negative patients that can get it often from the Mediterranean areas. About 60 to 90% of cases co-express EBV. So our case was negative, but it doesn't exclude it. And usually, as I said, patients present with pleural effusions, but they can also present with regional lymph nodes, bone marrow, skin, and involvement of the GI tract. And these lymphomas are negative for typical B and T cell markers. And interestingly, CD30 is commonly strongly expressed in this lymphoma. So in the end, this case was signed out as HHV8 associated malignant lymphoma. We didn't commit to primary effusion lymphoma because we didn't have a biopsy from the lymph nodes. Well, sorry, I'll be a little more accurate. We did have a biopsy from the cervical lymph node, but it was a very tiny core, and all it showed was polyclonal plasma cells that were HHV8 negative. So we weren't sure of the significance of that. And we felt we couldn't completely exclude that the patient had multicentric Castleman's disease and that it just was poorly sampled on the cervical lymph node biopsy. And therefore, without having a better biopsy from the cervical lymph node, we couldn't fully commit to primary effusion, pleural primary effusion lymphoma. So we sort of backed off a bit and gave them the discussion. Unfortunately, the patient at this point was already sent home, and unfortunately, he passed away before he was able to make it back to the hospital. So the next case is a 77-year-old male with an omental lesion core needle biopsy. So this is a low power view of the core needle biopsy. We can see some adipose tissue and fibrous tissue and some atypical sort of torn up cells. So on higher power view, this is what the neoplastic cells look like. They have this like clear cytoplasm around them. Again, vaguely plasmacytoid, somewhat maybe of an alveolar pattern. There's some fibrosis around the areas. And I honestly wasn't sure if this was hematolymphoid. My first panel was a CK pan, S100, and a CD45. And the CD45 came back positive. So then I went on to doing a CD20, CD30, and CD3. The 20 was completely negative. CD30 was also interpreted as negative. It just showed some non-specific blush staining. And then CD3 was also negative in the cells of interest. Then I did a CD138, a lambda, and a kappa. And CD138 was very strongly diffusely positive. And then lambda in situ hybridization was also positive. So what stains would you do next to solve the case? And this question is like, obviously all these things wouldn't be a bad idea, but it's more like if you only had, you know, one answer and you were out of tissue, which one would you go for kind of situation. Okay. And so we'll move on. And so what's our differential diagnosis for CD138 hematolymphoid malignancies? So obviously plasma cell myeloma comes to mind, like an extra osseous plasmacytoma. Plasmablastic lymphoma would also be in the differential. Primary effusion lymphoma, as we just learned, is also CD138 positive, usually. And then ALK positive large B-cell lymphoma is another entity that's less well known, but is also diffusely strongly positive for CD138. And so further B-cell markers were negative, EBV was negative, CD56, CD117, and HHV8 were all negative, and Ki67 showed a proliferation rate of 60%. And interestingly, the ALK was positive in all the neoplastic cells. So in the end, this case was signed out as an ALK positive large B-cell lymphoma. So this entity is very rare, but it is listed in the WHO, and it is an aggressive lymphoma that's characterized by chromosomal translocations or rearrangements involving the ALK locus. And now that we have drugs like rituximab or something, that there is a potential for these patients possibly being treated with those ALK targeting drugs. This lymphoma is both identified in pediatric and adult populations. It often presents in the nodal locations, particularly cervical, though this case was presented in the omentum. And it does exhibit a plasmacytoid morphology, and it will be negative for all B and T cell lineage markers, and it's often negative for CD30, or it should be negative for CD30. Interestingly, it will stain just like plasma cells. So it will be CD138 positive and MUM1 positive. And so then the question arises, well, do I have to throw an ALK at every single plasma cell neoplasm I encounter? And the answer is no, because it has a very characteristic morphologic appearance. the cells are often separated by fine fibrovascular septa and imparting an alveolar pattern. So if you just have like a regular looking plasmacytoma, I wouldn't be throwing an ALK at it. But if it looks a little bit more like this, where the cells are kind of discohesive, there's fibrosis, and they're sort of clustering into something that looks like alveoli, then it's a definite consideration. And that's it for me.
Great, thank you, Alexsandra. I think these were very interesting cases. And I think too, especially the second one, sometimes with these large cell lymphomas, as you said, it can be a bit tricky at the beginning to know what they are. And depending on the panel that is done, I've seen cases where you have some partial or sometimes even relatively impressive keratin positivity, which can throw off people a little bit of the diagnosis, depending again on exactly which stain were done in the initial panel. So these can be tricky, and we need to kind of remember to think about these entities when we have these cases. So Ali is asking, what was the pattern of ALK staining?
Oh, that's a good question. It was cytoplasmic, and I know that I don't know the patterns, but I know like if it's nuclear and cytoplasmic, it implies this translocation. If it's cytoplasmic, it implies that one. Unfortunately, this patient passed away as well. He had a stroke, and he never received treatment or even seen a pathologist.
Great, thank you. Are there any other additional questions or further comments?
And then the question about, is that typical ALK staining? Yeah, there's different patterns described, and one of them is just cytoplasmic. And our ALK stain, it always like dimly stains like that. So that ALK looked just like the positive control.
Great. Well, thank you so much.
Thanks.
So again, if there's additional questions, you can just, we can keep them for the end. And so we have our final presentation. So Carlo and Adam, if you want to share your screen. So Carlo Hojilla, whose primary research interests lie in informatics, data analytics, and how they impact lymphoma diagnosis and prognosis. Also interested in computational tools that employ various programming languages, statistics package, and image analysis software that are used to interrogate different clinical, pathologic, and technical data sets. And Adam Smith, who's the director of our cancer cytogenetics laboratory at UHN. He's an assistant professor at U of T, and he's currently, as I said, the director of the Cancer Cytogenetics Laboratory, and he's a dual-boarded clinical cytogenetics and molecular genetics laboratory scientist.
Okay, can everyone see my screen okay and can hear me?
Yes.
Okay, so many thanks to the organizers for first organizing this forum. I think it's great. And secondly, thank you for inviting me to present this wonderful case that Adam and I shared, which is titled "Let Sleeping Dogs Lie." So out of curiosity in the chat there, does anyone know who this idiom is most associated with or supposedly popularized it? Just out of curiosity. Just something off the beaten path. Yeah, so this actually goes back to Geoffrey Chaucer, English poet way back in the 14th and 15th century. The idiom is meant to imply that you can never predict the behavior of a sleeping dog. Although, I mean, looking at this little guy here, I mean, come on, how mean can this be, right? But anyway, that's right. Do not disturb. So this is a bit of a cautionary tale for an interesting case. Pretty simple diagnostic case, but then there's complications. So without further ado, clinical history. This was a 57-year-old male presenting with a rather large intra-abdominal mass, 14 by 6 centimeters, with very kind of aggressive features, invasion into the left renal pelvis, mainly a retroperitoneal location. Very PET avid, high SUV in the abdomen, about 25 or so, minor uptake in the neck nodes of about 5. So, you've got both above and below diaphragm, stage 3 looking like. But interestingly, LDH was normal. There was no anemia. There was no problems with the platelets. Everything was normal. So they decided to biopsy. And again, I always find it interesting that, you've got a 14 centimeter mass and they give me one core, a 2 centimeter core biopsy. But it is what it is. And so there's a reason why there was a repeat biopsy. So for the most part, I'm going to try and go through the different case, both biopsies side by side, just to show you what we're seeing. But before we get into that, I want to launch the first poll. So if you were thinking of a lymphoma in the retroperitoneal space, which one would you think is probably the most common? So to the audience out there, I always find it really cool to see the answers coming in. So right now it's a close tie. So get those answers in. We'll do about 5 more seconds. Don't be shy. I don't think these are not these are all anonymized. So okay, we'll end there. Share the results. Yeah, I think so. Understandable that people would think it's the 2 germinal center type of lesions, but I would actually argue that it's the latter, the more indolent one. Follicular lymphoma tends to be the one that's more retroperitoneal. In fact, if I was a betting person, if someone gave me a core of query lymphoma coming from the retroperitoneal space, I would put good money on follicular lymphoma. Never, I'm not saying that all those other ones don't happen, but most commonly follicular lymphoma. And follicular lymphomas in the retroperitoneal space tend to have like this very fibrotic look to it. And you often get very minimal sampling. But in this case, the minimal sampling was just because they just chose to minimally sample for whatever reason. So anyway, let's continue on. Sorry. Oops. Am I still sharing my screen?
Yes, we still see the clinical history slide.
Right. Okay, so these are side by side of the 2 biopsies. The point here is to just show you that these are the cores that I got. Admittedly, in the second biopsy, they gave me more tissue because that's what I asked for, but we'll get to that. But you see very healthy cores, very cellular cores, just showing you kind of like this diffuse-ish, maybe some nodular pattern on this left-hand side core, some nodules here, nodules there. You're seeing my arrows, right? Hopefully.
Yes.
Yeah, okay. Nodules there, nodules, and maybe some big nodularity in the second biopsy. On closer inspection, again, it just kind of highlights some more nodules here, maybe some diffuse areas, some nodules here, and same thing. So, and at least from this low power, you're not seeing any necrosis. At least the cells don't look large or obviously large because they would usually jump out at this power already. And to be honest, at this look, I'm still kind of thinking, okay, it looks like it's going to be follicular lymphoma. And indeed, on higher power, hopefully everyone recalls that follicular lymphoma tends to have are known for these centrocytes or elongated nuclei with some cleaving, which you can see predominance of the cells are centrocytic. And you only very rarely will see the bigger cells, such as the centroblasts. So this is so far all in keeping with a centrocytic proliferation, at least from the H&E. And really in terms of preliminary type of diagnosis, just based on the H&E, I would again put my money on follicular lymphoma just because of the mostly the centrocytic type of proliferation that we're seeing here. And in the biopsy, the second biopsy, it's also similar. This was more in the more nodular areas, but again, showing you just mostly a small cell type of proliferation with these elongated nuclei that are all consistent with centrocytes. And importantly, you're not really seeing a lot of centroblasts. Maybe there's just this one area over here that's centroblastic. So yeah, so far, so good, at least from a preliminary, from at this stage, it looks like it's going to be a small indolent B-cell, or sorry, small indolent lymphoma, small cell lymphoma, and all the differentials that come with it. Next stage here is an activity that I like to do. If you can indulge me, if you can turn on the annotate button on Zoom, please feel free to put a check mark or a stamp to where these markers on the left fall under these small lymphoid proliferation, small cell lymphoma entities. So where do you, which ones are these are usually typically CD10 positive, which ones are CD5 positive, which ones are BCL2 positive, cyclin D1, etc. I always like this activity because it gets everyone moving. And hopefully, you're taking a break from looking down your microscope right now, which is okay too, you can do. But if you'll indulge me, I think it's a pretty neat idea. And also gives good discussion. If you don't know where the annotate button is, it's on if you move your mouse to the top of your screen, it should be at the bottom, click on annotate and you'll be given different options of like a check mark, a line, a stamp, anything like that. Just feel free to click away. So yeah, so we're seeing some neat patterns here. Sorry, there's a hand, Alexsandra.
That was me trying to annotate.
Sorry.
Okay.
Onions, cucumbers.
Okay, so interesting. Thank you for participating.
Green peppers and banana peppers, please.
Okay, someone's ordering lunch. That sounds yummy. So it looks like we have follicular lymphoma, as most people have identified, CD10 positive, which is a germinal center marker. CD5 is typically a T-cell marker, aberrantly expressed in two types of B-cell lymphomas, which people have correctly identified here, mantle cell and small lymphocytic / CLL. BCL2 is really the non-specific one, right? It can be expressed in a whole host of, B cells, T cells, whatever. It often has an association with follicular lymphoma, but I would be remiss if I didn't mention that there is a certain subset of follicular lymphomas that are BCL2 negative. So just be careful about that. But certainly BCL2 is positive in mantle cell and very, very strongly positive in small lymphocytic lymphoma. And good on everyone for picking cyclin D1 as really just within the domain of mantle cell lymphoma, which is quite pathognomonic and diagnostic marker for mantle cell. So thank you all for that. We'll clear the drawings and stop the annotation. Oops, going back. So given all that, just want to quickly summarize the marker because again, from a diagnostic point of view, this was pretty straightforward. The histology supported what looked like a low-grade follicular lymphoma, and indeed it's CD20 PAX5 positive, CD10 and BCL6 positive, and BCL2 overexpressed. And interestingly, Ki67 is pretty high for this. And if you recall from, hold on, which one do I have here? Oh yeah, and then CD21 and CD23 is always useful. Sorry, CD21 is always useful for these types of cases because it really helps delineate where those boundaries of follicular dendritic networks are going to be. And so as you can see here, correlating to what we saw in H&E is that you do have some nodular areas that have some expanded, maybe eaten away follicles. Follicular dendritic networks, some more intact ones, some smaller one, but also you have some diffuse areas in between. So at this point, I was pretty happy based on the cores that I had to sign this out as a follicular lymphoma low grade, grade 1-2 or 3. And, none's the wiser, I thought pretty straightforward. And in fact, without giving, I guess I'm going to give it away, but the repeat biopsies also showed there. But this is where it kind of got interesting because given the large mass, given the high SUV on PET imaging, the clinician was really, really worried about the patient The patient was fine, by the way, clinically. And a couple of emails back and forth and phone calling, and it's like, could you send it for cytogenetics for fish? And I'm like, why? There's really nothing. He's like, well, and I'm like, I don't know. I'm still relatively new at this. I still haven't learned how to say no properly, I guess. So after back and forth, I relented, which is where the story gets interesting. Because this was the biopsy one result, is that it's a germinal center immunophenotype, centrocytes, and maybe some centroblasts are present. Maybe there were some diffuse areas, but certainly no areas of centroblasting approaching grade 3 morphology. There's no definitive areas of transformation. I said at most it was probably grade 2, 1 to 2 of 3 with some diffuse areas, sent for cytogenetics, but lo and behold, it showed double hit. But before we get to that part of the story, let me share my next poll. So with respect to follicular lymphoma, which of the following is typically not a prognostic factor? This is a tricky one. Okay, again, don't be shy. Get those answers in. We'll do about 5 more seconds. We'll end there, share the results. Okay, I'm happy that no one chose centroblast count because, as everyone knows, that's part of the grading. The other ones are a bit more controversial, I guess, from this spread. So let's do it one answer at a time. So site can actually be a prognostic factor, right? We had presentations earlier of, especially in kids, cutaneous follicular lymphomas tend to be very indolent in nature. Duodenal type follicular lymphoma, no one really even knows if that's an actual lymphoma because they do so well. And then certainly follicular lymphomas that are higher grade or in higher grades, but in sites that are a bit more compromised can be a prognostic factor. Proliferation index is challenging at this point. There are studies showing that even low-grade follicular lymphomas with high proliferation index, we're talking about greater than 40%, can behave as aggressively as grade 3 follicular lymphomas. And it's not uncommon for people to report follicular lymphomas with high MIB index as a top-line diagnosis. And it's also not uncommon for clinicians to ask about, high proliferative index, low-grade follicular lymphomas. Diffuseness is the answer that I was kind of looking for. And the idea here is that just because I think a lot of us and clinicians included have been kind of trained to have this word diffuse as a triggering word, I'm really trying to avoid or at least dispel that myth because, often when you say lymphoma is diffuse, automatically people kind of tend to zero in on DLBCL, when in reality, there are a lot of, especially follicular lymphomas of the inguinal canal, that subtype that tends to be primarily diffuse and is very indolent. So diffuseness, if I can make that my little rant for today, is that it's not often associated with as a bad prognostic factor. Okay. I just realized that I probably misworded this question here. What I was meaning to say was not a bad prognostic factor. So my apologies for that, for a bad question. Nonetheless, it still was fruitful for discussion. So going back to the case, I think I'll hand it over to the reins because again, the big surprise, in movies when they have those spit takes, like this was a spit take moment for me, but I wasn't drinking water and it wasn't like I was talking to someone to actually spit on them. But when I saw the report from Adam showing that this follicular, what I call follicular lymphoma grade 2 was a double hit lymphoma, my jaw dropped. So Adam, please take it away.
Thanks, Carlo. I'm going to ask you to forward the slides for me if that's okay.
Of course.
Yeah. Okay. So yeah, we did get a double hit result with this patient, and one of the things that happened right away is Carlo had contacted me and said, I really wasn't expecting this result. And so when we hear that, of course, we think, well, you know, there's lots of things that can happen that could cause an unexpected result. Obviously, the first one is biological, and that the result is actually real and something's going on. But there are other possibilities. So we could have mixed up a probe in the lab. We could have mixed up a slide. There's a whole bunch of technical potential explanations, and we like to do a thorough investigation whenever that happens and make sure we are looking at all of the possibilities. So we took a step right back to the beginning, and we said, okay, let's have a look at everything here and see what's happening. So for MIC, for our panel now for double hit, and for triple hit, our large B cell panel, we're using a MIC break apart probe, a BCL2 break apart probe, and a BCL6 break apart probe. So they basically all look the same. So we had to go back, we had to refish everything, and because we knew this was a patient that probably had a diagnosis of follicular lymphoma, we were pretty confident the BCL2 was going to be positive anyway. So if the BCL2 and MIC had been switched, we wouldn't have been able to tell the difference under the microscope. So again, everything getting repeated there. And so we also had to look at all of the other patients that were on the same run with this patient and make sure that we didn't have any unexpected results in those patients. If we had mixed up a probe, we would have probably done it in a batch, and it would have affected potentially a bunch of other patients. So thankfully, when we repeated all the results, we did get exactly the same results on all patients that we had got originally. And it was fairly clear that we weren't looking at a situation where there had been a technical error. Next slide, Carl. So, oh, yeah, sorry, I don't know why that little circle became orange there. There should be just 2 green circles and the rest should be red circles. So on the left-hand side of your screen where the orange circle is, just imagine in your mind that it's green. So this was our first report that went out from the first biopsy, block A2. We had 59% MIC positivity and 59% BCL2 positivity. And then we ended up doing a lot of other investigation on this particular tumor, as it turned out to be very, very interesting. So we received the second biopsy just under 3 weeks later on May 21st. And again, we performed the full panel and MIC was negative. And then we went back to look at the biopsy 1 block A2 again and repeated it, and it was negative. We looked at several other blocks at this point. So on June 2nd, biopsy 2 block A4, also negative. And then going on June 4th, because we were now also getting extremely worried about what was going on, because we were clearly seeing some cells that were positive and other repeats and other blocks were not positive. So this is not a very usual pattern that we see with these kinds of tumors, where we see, you know, very different results in different blocks. It tends to be much more uniform. So what ended up happening is in these final blocks, what we came to understand is that there was a very, very small area of MIC positivity within a couple of the blocks that we saw. And the majority of the rest of the tumor was negative for MIC positivity. Next slide. So a picture, as they say, is worth 1,000 words. So I did want to show you some pictures of the different blocks and the MIC break apart probe to convince you, in fact, that we were seeing these different patterns. So on the top left corner, you can see biopsy 1 from block A2, which we originally called positive. And you can see that there are some broken apart signals in that particular quadrant. And then if you look at both the top right and bottom left quadrant, these are from biopsy 2. and they're both negative, of course. So again, not seeing any of the broken apart signals in those. And then finally, in the lower right quadrant, this was a repeated specimen, biopsy 1, block A2, again showing positivity. So we're seeing this different pattern in this tumor. Next slide. So where we came down at the end of the day was we realized what we were seeing was a very focal phenomenon that actually represented an extremely small area within the tumor. And so part of the issue here comes, when you were doing this kind of analysis, when we're doing FISH analysis, we're looking at a relatively small number of cells. And standard analysis, 200 nuclei, and it's done at relatively high magnification. And so when we actually started, so when technologists look down the microscope and they start to look in the area of interest for cells, what they do is they scan the entire area to see if they find areas that stand out, that don't look like they should, that don't look normal. And then when they find those areas, they focus in on that area and they can score. And so sometimes if there are very focal clusters of positivity, you can see distortion in the proportion of positive nuclei, which is in fact what was happening here. So in certain areas, we were seeing anywhere from say 20 to 50% of nuclei that would show a positive signal pattern. But in fact, when we zoomed out and looked at the sort of the overall tumor, we realized that the positivity rate for the probe was actually probably in less than 1% of cells. So this is a very unusual finding. We don't usually find, it is possible to find scattered cells that are positive, but to find clusters of cells like we found where many cells that are in an area together are also positive is a very unusual finding, and it created quite a lot of work for the lab, as we had to do a thorough investigation on many blocks and repeat the count several times to really get down to the heart of actually what was happening. And so, of course, the consideration was that if there was a small focus of MYC positivity, did this have something to do with transformation of this follicular lymphoma? So next slide, Carlo.
Oops, sorry.
Yeah. So this just to sort of visually represent what I was trying to say in the previous slide, is that when we go at the various levels of magnification, it's just important to remember that we're really subsampling a very small proportion of cells. And so at a standard sort of 10 or 20x magnification, you're seeing sort of pieces of the tissue in a more holistic method or manner. And then as we move up into higher magnification, so typically where we perform epifluorescence at with a 100x oil objective and a 10x ocular, we're up to about 1,000 times magnification, which means that in any individual field, we're not actually seeing that many cells down the microscope. And I think back to you, Carlo.
Okay, so so this really was an exercise in communication, and I applaud Adam and his team and the lab at UHN for just really being on top of this. It was just really amazing. Like I said, as Adam said, as soon as I got the result, after collecting myself, I was on the phone with Adam and just seeing, hey, what do you need me to do? And in terms of because after that first biopsy, they gave me a little sampling, and pretty much the idea was that let's do this again, but give us a lot of samples so that we can test everything. And pretty much Adam was like, can you give me another one of the first biopsy? Can you give me a second one of the second biopsy? And I'm like, yes, whatever you need to try and sort this out. So if you can imagine being in the patient's perspective now, it's been a month with this very uncertain diagnosis, being told that this was going to be a double hit transformed. The patient was very, very anxious and was also very well informed. sought another opinion from the best doctors. In this case, they sent the case to Washington, someone in Washington, and a combination of both an oncologist and a hematopathologist reviewed it and agreed that this was a low grade. But given the cytogenetic findings, that they preferred that this was one of these transformed follicular lymphoma, whatever that means. And the best doctor, Hemong, at that point actually recommended going with our EPOC full on for a grade 1-2 follicular lymphoma. And so, yeah, so the patient was just really frustrated because there's this many disease. So I mentioned the communication between me and Adam. I was on communicating with our Hemong here, as well as people at UHN to try and really come up with a more, an overall comprehensive. Bottom line, we stuck with a grade 1-2 follicular lymphoma, no evidence of transformation, and with those explaining, you know, how we kind of sorted out that cytogenetic finding. The Heme-onc also consulted with multiple Heme-oncs, both at our site and at UHN, and decided that they were going to treat with the standard treatment for follicular lymphoma, which is Benda, Ritux, and maintenance Ritux. Again, depending on where you're from, there's a lot of good evidence for Benda as a first line for follicular lymphoma. So since then, dramatic radiologic improvement by cycle 3. And complete metabolic response by the end of cycle. There was still a residual mass, which, you know, it wasn't PET avid, but decided that just for increased local control, they were going to treat with 30 grays in January. And throughout this whole process, the patient was doing well, especially, you know, Benda is a lot more, BR is a lot more well tolerated. And so the patient continues to do well, is what I'm trying to say. So. And I think that's it. So if there's any questions, here are our contact info, and hope that that was as interesting a case for you. And many thanks again for the organizers for inviting us. And I will stop my share.
Thank you for a really engaging presentation. I think, as you said, it really highlights the importance of communication for these challenging cases, especially when we're in kind of gray areas. I think Ali has a question. Go ahead.
Yeah, thank you. It's not actually a question, it's more like a comment that, like two different comments. Like first one, that if we have double hit, I mean, BCL2 and MEEK, in a well-formed follicular lymphoma, that's not a double hit lymphoma. So we should avoid from making that diagnosis a double hit, because double hit implies the notion of a high-grade B-cell lymphoma. And there are literature that as long as we have that follicular structure, the prognosis is not as bad as a high-grade B-cell lymphoma that is diffuse. That's one thing. The other comment is, like, it kind of raises this interesting thing. Did you, Carlo, stain for MEEK as well?
Yeah, so
did it highlight some areas that is MEEK? No?
No, it was dead negative. So if I can address your first point, so that was exactly the type of conversation I had with the Heme-onc. But the Heme-onc, like I said, similar to how diffuse is kind of that triggering word for them. When you say double hit, they automatically think double hit lymphoma, right? And so regardless of any conversation, or try as I may to try and kind of lower down that volume and that worry, still could not escape the fact that in their head, this is going to be a double hit lymphoma.
Yeah, that's the reason that we shouldn't call this double hit, because this actually
that
is actually 1.1 hit, not 2 hits. It's like 1 hit in all cells and 0.1 hit in like 10% of the cells. So it's not a double hit lymphoma. But that's interesting if we do MEEK in all low-grade follicular lymphoma to see if we can pick up some foci of early transformation. That would be nice.
Yeah, so in this case, it was actually negative. And this was only after the cytogenetic result that I did it, because again, it was all follicular lymphomas as far as I'm concerned. I usually do like a low a small cell panel, and certainly MYC was not part of that. And this was after, because I was worried that, after this result, like what if I ordered an immuno and it's lighting up? And yeah, it didn't actually even light up. It's not even clusters. So.
Dr. Ngan has a question as well.
Yeah, brings back memory. I was at Sunnybrook for 7 years. At that time, I was keen on doing cultures for follicular lymphoma. I did have a double-hit lymphoma. It's a very aggressive disease. I actually retrieve it from pleural effusate on an autopsy. I think the patient can tell us if it is a double-hit lymphoma. They're gravely ill. They're high stage. Yeah. And the cells that I have, they are large B cell, almost like ALCL-like. And the challenge I had at that time is I put it into Newton mice, and the lymphoma grows so well. I keep getting call from the animal services, says you better do something about your mice. They look very, very sick. And then to extend, I can't even go away. Every 3 days I have to feed them. So it's for real. If it's oncogenically driven by MYC, these cells, have unique morphology, and they also, very, very aggressive. So the other point, I'm not a fish expert, but I always think that fish probably is more reliable than untouched preps when it comes to cut sections. Depending on, there are areas that when the microtome cut, it may actually, as you know, cut section is a section of a hard-boiled egg. When you do touch prep, the cell is like, easy over. Everything is there. So the nucleus will not be disturbed in a touch prep, whereas in the cut section, it may be variations where, different part of the sections, randomly cut through, and it may be very challenging on evaluation on break apart and so forth. So yeah, so it is challenging, but in follicular diffuse lymphoma, I usually scrutinize the diffuse area, make sure I do not see transformed cells, and that would be quite helpful as a start point.
Yeah, again, certainly the learning point for me here is to just, kind of build up that, in retrospectoscope, if I were to put that on, I probably would have been a lot more firm in terms of just saying no. But understandably, the clinicians were very worried. Given the retroperitoneal location, they couldn't really sample a much larger area. The size, the SUV avidity, but and I was trying to point out that, hey, there's a lot of low-grade follicular lymphomas that are also very PET avid, or metabolically active, I should say. Again, the learning point for me here is that I probably would have been a lot more firm in terms of just saying no, just given everything that I was seeing. Nonetheless, I always advocate for this, that, if you order a test, you better be prepared to interpret, or ready to interpret one way or another how it goes. And I'm just so glad that Adam and his team were just right on board with me, and everyone was on board to try and sort this out. So.
Yeah, I think you're answering Hassan's question. Do you regret sending this for fish? We also had one more question in the chat from Dr. Pacheco Blandino. He's asking, what's the rate of progression/transformation into high-grade B-cell lymphoma for this type of follicular lymphoma with double-hit translocations?
So again, secondary to Ali's point, you want to try and avoid that double hit terminology, because it implies, and I think that's why the new WHO also has come out with a different terminology, right? Because it's a very misleading term. Certainly when you have MYC, you can have MYC rearrangements in diffuse large B-cell lymphomas just by themselves. It's a bad prognostic factor. I'm not really quite sure in terms of the transformation rate when you have both. So you'll expect to have BCL2. So I would open it up to my colleagues if anyone has a smarter answer than what I can provide regarding that rate of transformation.
I'm not sure. I would have to check the literature to see if there's any kind of clear.
Yeah. But again, you stick with follicular lymphoma. It's a follicular lymphoma, right?
Yeah,
same
exactly.
thing if you have a diffuse large B-cell lymphoma that looks like has a Burkitt's immunophenotype, you're still going to call it diffuse large B-cell lymphoma, right?
Yeah. Yeah.
Yeah,
Exactly.
but in general, about 5% of low-grade follicular lymphoma would transform, but not necessarily double hit. So many
Sure.
of them have TP53 mutation,
Yeah.
for example. So it's
Yeah.
double hit BCL2 TP53 mutation.
Yeah. So I'm just trying to be mindful of everybody's time because we're at the hour. So just, I think, Adam, you have your hand raised. Just before, to make sure everybody knows, Jenny has posted the evaluation survey, which you must complete if you wish to receive a CPD certificate. And please, we're very interested to have any comments or suggestions to improve. This was our first iteration of the community of interest, but we really want to, we can take this into any direction that will be interesting for people and will serve the needs of the community. So maybe just in a few minutes, shortly, Adam, did you have a comment or a question that you wanted to make?
Yeah, I just had a very, very quick comment about nuclear truncation artifact. So in FFPE cuts where we have truncation artifact, generally the problem with truncation artifact is related to the distance the two probes are from one another. So if two probes are actually very close together, the probability of having truncation artifact is very low. And then as you move the probes further and further apart genomically, the rate of truncation actually increases. So when you're looking at enumeration probes, for example, if you have a centromere probe and a target probe on a chromosome arm, the further they are away, the more likely you can have truncation or one of the other signals. When the probes are usually close together, like in a break apart probe, it's very unusual to truncate between the space. It's extremely unlikely. And that's reflected in our validations.
Thank you. And there was one last question from Sadaf in the chat. She's asking, could this already be transformed as it was a large mass and only a small biopsy tissue was submitted? So, you know, we can ask ourselves, was this representative? I don't know, Carlo, in terms of.
Yeah, so that was the whole point of the
had.
second biopsy set. And I told him, I know it's retroperitoneum, you can't take that out, but give me a lot. And, you know, to their credit, interventional gave me a lot of sample. And so the idea that as much as we could, this is probably going to be most representative. And in both cases, it showed the same thing. There was no areas of transformation. Although if you believe that third opinion or from best doctors that, you know, this is likely transformed, then, you know, you can't, nothing's 100%. Mm-hmm. And as Dr. Ngan mentioned, that the patient was actually well throughout this whole point, right? Outside of the worry and the frustration from what was happening, the patient was well. LDH was just normal and CBC was fine. So yeah, I think that's really the main takeaway there.
Yeah,
so
and as you said, the morphology was what it was. If you don't have morphologic evidence, then one needs to be cautious about changing diagnosis purely based on cytogenetic result. Yeah. Well, thank you so much. I think this was a great first meeting, and don't want to take more time from people. I think we did reasonably well trying to respect the time that we had. So again, just please fill out the surveys and provide any comments. And thank you all for our presenters who volunteered to be presenting at this first meeting. And we'll be letting you know shortly about our next one. And we already have interesting presentations lined up. Thank you, everyone.
Bye, everyone. Thank you.